Good afternoon, everyone. My name is Geeta Mehta, and I'm from the University of Toronto. Thank you for coming. I hope you had a good lunch, and happy Valentine's Day. I'm going to speak about my favorite topic, and that is comfort management in the ICU. And I prefer to label it as comfort management now, as opposed to the generic sedation management in the ICU. And hopefully at the end of this, we'll have some time for a discussion, and I'd like to hear about your perspectives and how you've all managed to lighten sedation in your ICU. So what I'm going to speak about is the consequences of too much sedation, how we might optimize patient comfort management in the ICU, specifically mechanically ventilated patients, and what strategies have been shown to effectively reduce sedation exposure, and a little bit about maybe drug choice, physical restraints, and then sleep. And this is a paper published in the British Medical Journal in 1941 on acute bronchiolitis in children. And alcohol is the best sedative for children. Brandy, whiskey, or port may be used. Doses may be individually determined. I know it's the best sedative for me, but I don't think it's the best sedative for children nor for adult patients in the ICU. But just to illustrate that certainly the field of sedation has progressed. So based on much really good literature over the last couple of decades, that we know that it's no longer necessary to keep people deeply sedated and unresponsive in the ICU. Certainly when I started working more than 20 years ago, all of our mechanically ventilated patients were kept deeply sedated until the underlying condition had resolved, and then we started to wake them up, and invariably it took days, sometimes weeks, for them to wake up. We used a lot of benzodiazepines then, so as you know, the benzodiazepines plus opiates resulted in big depots within the body. So we figured out strategies whereby we don't have to deal with that and our patients don't have to deal with the consequences. So there are consequences of too much sedation, and they've been well described. Too much sedation is associated with longer durations of mechanical ventilation, longer weaning time, longer ICU length of stay, longer hospital length of stay, more skin breakdown, maybe a higher incidence of venous thromboembolism. Patients are more likely to have tracheostomies, which is an important outcome. This was a study in pediatric patients from the age of just a few months to a few years, and it was published in 2018. It was following pediatric cardiothoracic surgery, whereby the control group was randomized to continuous infusions plus intermittent opioids and benzodiazepines, and the intervention group was randomized to purely intermittent doses as needed, as guided by patient assessment using pain scales and sedation scales. The intervention group received lower doses of benzodiazepines and opiates, and on top of that were extubated and discharged from the ICU and from hospital sooner. So it is possible to use intermittent dosing in most patients, if not all, and it results in better outcomes. Not only is the amount of sedation important and impactful on important patient outcomes, but it appears that the timing of sedation is also very important. And Dr. Shahabi from the ANSICS groups has done a lot of work in the sedation area, including a paper in the New England Journal of Medicine last year that I'll tell you about shortly. But he started off this area focusing on early ICU care with some observational studies. And this was one of the first ones he did. And what he found is that if he compared patients who immediately after intubation and early in their ICU stay were deeply sedated, as expressed by a RASS score of -3 to -5, and he compared them to patients who were not deeply sedated, the deeply sedated patients, even if it was only in the first 24 hours, had a slower time to extubation and lower mortality. lower survival, so higher mortality. The time to extubation we can understand. The impact on survival is less explainable. We know around the world that despite strong literature showing the benefits of light sedation, that patients continue to be deeply sedated. And we understand why that is, and I'll show you some data on why many nurses, why many clinicians prefer to keep their patients deeply sedated. And this was a nice study, multi-center study from Peru, where they followed more than 1,000 patients for 18,000 ICU days. And I really like this figure, that's why I'm showing you this paper. And this deep blue is deep sedation. This lighter blue is moderate sedation. And what they found over the days in the ICU, and this is unassisted breathing down below this dark line, and death. What they found is that the majority of patients up to the time of extubation, up to the time of liberation from mechanical ventilation, were kept deeply sedated. And just when it was planned to extubate them, that's when sedation was lightened. But most importantly, they found that the percentage of days with deep sedation was associated with 90-day mortality in an analysis that was adjusted for age, severity of illness, ICU, with an odds ratio of 5.4. So 5 times the risk of dying if patients are kept deeply sedated. The other thing that's important here is, and this is going to be a theme about avoidance of benzodiazepines 100% if you can, except for certain exceptions. The cumulative dose of benzodiazepines was an independent risk factor for dying in the ICU or dying at 90 days. So 2 points here: people are kept deeply sedated, and the risk of dying associated with too much sedation and benzodiazepines. Yahya Shahabi established this sedation index, which is calculated over the first 48 hours of mechanical ventilation. And a higher sedation index reflects greater sedation intensity. And the index is very simple. You add up all of the negative RASS scores, and as you know, negative RASS scores reflect sedation, and you divide it by the total number of RASS measurements. So again, the higher the score, the more sedated these patients are. And what he found when he divided the sedation index into tertiles, lowest, middle, and highest, is that patients with the highest sedation index were less likely to be extubated quickly. So slowest weaning, slowest extubation. And also the patients with the highest tertile, so most sedated, were more likely to die. And there was a gradation here across the 3 tertiles. And every 1 point increase in the sedation index was associated with a delay in extubation by 1 day and a higher risk of dying in 6 months. So we still have a lot to work out in terms of why sedation is associated with a higher mortality. But he went on and designed his recent dexmedetomidine trial with the primary outcome of mortality, and I think that's the reason it failed to show an outcome. That's the wrong outcome, but that is the basis why that was his primary outcome. So we all take care of patients who are transferred to us from the emergency department. Down there, they're intubated, and most often they come to my ICU deeply sedated on opioids as well as benzodiazepines, with no particular reason other than the emergency department is busy, the nurses have other patients, and it seems like the degree of sedation of those patients is associated with worse outcome as well. And in this study, it was a multi-center study from the US, and they evaluated specifically that population who got intubated in the emerge, and then there was some delay in them coming to the ICU. 85% of them got fentanyl, 61% of them were getting midazolam infusions, 47% of them were getting propofol, 16% ketamine, and 5% were paralyzed. One of the concerning things here is not everybody was getting analgesia. And above all, we should use an analgesia-based approach with objective assessment for pain. And if you can't assess them objectively for pain, then you give them analgesia just in case. So the median sedation depth in the emergency department was a RASS of -3, which is moderate sedation, any movement but no eye contact to voice. And what they found is that these figures down here show number of days hospital-free and ventilator-free and ICU-free, and mortality. And this is the deepest sedation to lightest sedation. So patients with deeper sedation had fewer hospital-free days, ventilator-free days, and ICU-free days. The patients with the deepest sedation had the highest mortality. A RASS of -5 was associated with a mortality more than 25%. So this should make you question, when your patients come from the emergency department to the ICU, whether all the sedatives can be stopped, and also having discussions with the emergency department about specific indications for deep sedation in the ICU, in the emerge. So I kind of highlighted some of these consequences of too much sedation. The association with delirium, I don't believe. Many studies have evaluated doses of sedative in patients who are deeply sedated versus not, or delirious versus not, without showing differences in sedative medication and delirious patients reflect an acute brain dysfunction. And in some of our studies, we found that patients who were comatose or unresponsive had actually received lower doses of drugs, suggesting again that it's an intrinsic brain dysfunction. Patients that are sedated can't be mobilized, they can't engage with us or their family members, they can't contribute to decision making, the neurological exam is unreliable, and they may have imaging studies of their brain done because they're not waking up. I mentioned the stays and mortality. So this is really the ideal scenario. This is my objective when I take care of my patients in the ICU. I want patients that are awake and interacting with their babies and their families and writing me notes, playing cards. And I'd like to have my ventilated patients walking around. I can't say that happens often enough in our ICU. On Twitter recently, I saw a patient walking on continuous renal replacement. He had a jugular catheter, and of course it takes a team of support, but it is possible. Many countries around the world have established national quality improvement bodies, and this is ours, is called Choosing Wisely Canada, and they generate lists of 5 things that clinicians should know in different areas of medicine. And this is the 2017 list that came out for critical care clinicians. And number 1 was have goals of care discussions, but number 2 was don't prolong mechanical ventilation by the overuse of sedatives and bed rest. And also Choosing Wisely in the US has generated a list of 5 things physicians and patients should question. And number 4 relates to don't deeply sedate mechanically ventilated patients without a specific indication and without daily attempts to lighten sedation. So there are indications for deep sedation that we'll get into. So the goals of sedation and analgesia in 2020 are, above all, to relieve patients' symptoms. And many of their symptoms relate to distress around the tubes, the procedures, anxiety. So to relieve that pain and anxiety, keep them safe, keep us safe by keeping the patient calm, attenuate, improve compliance with care, and facilitate communication and mobilization. So questions I ask myself daily when I go in and visit my intubated patients: what is my patient experiencing? And the best way to determine that is to ask them, does my patient need sedation? And then why does my patient need sedation if the patient is receiving it? And in terms of asking what the patient is experiencing, ideally we can ask the patient and ask specific things. Ask, are you having pain? Are you anxious? Are you fearful? Are you sleeping? But if you can't ask them, there's some literature out there showing us what the patient experiences, and it's really a horrible experience. This was a study from the United States. 125 patients who had been mechanically ventilated were interviewed, and 81% of them recalled feeling fearful to a moderate to extreme extent. 84% of them recalled feeling that something bad was going to happen. 84% of them recalled not being able to sleep, and 86% of them recalled moderate to extreme pain. So this is what should guide our daily assessment and management of the patient. And management doesn't necessarily mean throwing drugs on board. A lot of these symptoms can be relieved, of course, by reassuring the patient that you're there to listen, you're there to watch them, and nothing bad will happen to them. We also have done some work in this area of what patients recall from their ICU stay, and the sleep study was a multi-center study whereby over 400 patients were randomized to sedation protocol or a sedation protocol plus daily interruption. And we followed patients for 90 days after they left the ICU using a memory tool called the ICU memory tool. It's been validated. It's to measure recollection or amnesia for the ICU, but also specific memories. And this also shows you that the experience of being intubated, mechanically ventilated in an ICU can be quite horrible. So a third recalled pain, panic, half feeling confused, half feeling anxious, frightened, and then 40% hallucinations and 34% nightmares. And only 3/4 remembered being in the ICU, only half remembered being admitted to the hospital. And this is a reflection of the ICU amnesia, which is most likely related to the encephalopathy associated with infection or sepsis, and doesn't seem to be related to drug effect. In terms of recognizing what's causing a patient's pain, of course, post-operative patients have pain. That's easy. But non-operative patients also have pain. And this is a really nice study by Kathleen Printillo, a very large study where patients were interviewed or surveyed to find out what the most painful procedures were while they were in the ICU. And I encourage you to disseminate this paper to everybody who works in your ICU. And some of these are not surprising, but some are surprising. For example, chest tube removal. So when you're inserting a chest tube, who gives analgesia? Not everybody? Yeah. When you're pulling out a chest tube, who gives analgesia? Exactly. So very few of you do. And that's because we assume that pulling tubes out does not cause pain. Wound drain removal, so chest tube removal and wound drain, abdominal wound drains, were the two most painful procedures. We also assume that it's quick, it'll be out, it'll be over. And then arterial line insertion, which should make us question why are arterial lines necessary in all patients? They are not. We don't need minute-by-minute blood pressure. And the importance of analgesia for these procedures. Suctioning is associated with pretty significant symptoms, pain, and that should make you question whether routine suctioning is needed versus suctioning as needed. And then endotracheal suctioning, tracheal suctioning. So those were the 5 most painful procedures. So my symptom-based management approach assumes that patients have pain, fear, anxiety, and cannot sleep well, and then I address the agitation as well. So always for symptoms, objective assessment. And as I said, if you can't ask your patients, then there are scales that have been validated for intubated, non-communicative, mechanically ventilated patients in the ICU, including for pain as well as sedation and for delirium. And then non-pharmacologic support I mentioned in terms of reassuring the patient, but also having family nearby. We have a 24/7 visitation policy. Families can come in at any time. They can stay all night. They are present during procedures if they wish to be. They're present during cardiopulmonary resuscitation. They're present during our ward rounds and can ask questions and contribute during that time. And I think that's very reassuring to families. And other non-pharmacologic support, making a nice environment for sleep at night with the lights down, with alarms down, and familiar objects, the patient's pillow from home, anything that's needed that will make the patient more comfortable. We do have pets visit occasionally, but not as often as I'd like. And then if medications are needed on top of that, you choose the right drug for the right symptom. No longer benzodiazepines for every symptom. And we use a lot of adjunctive therapy, a lot of non-opioid analgesics. We use a lot of anti-anxiety drugs. And then physical restraint I have in parentheses because they are necessary in an extremely agitated patient to keep the patient safe and to keep us safe, but it should be a short-term solution. So I mentioned some of the validated scales out there, and I'm sure all of you use these scales. There's pain scales, sedation scales, and there's probably more than 20 or 30 sedation scales that are being used. The ones that are used most often around the world are the RAS, the SAS, and the Ramsey. And I recommend against using the Ramsey. The Ramsey was developed, it was the first scale developed in the 1970s, and it was developed not for ICU patients, but for patients under anesthesia. And the reason I recommend not to use it is that it only has one category in the anxious or restless or agitated sphere, whereas these other scales have agitated, very agitated, dangerous agitation, and similarly. And we know there's great gradations in agitation, and if you have a protocol or some kind of algorithm that's being guided by this scale, then it's very difficult to decide what to give if all you have is this score of 1. Who monitors their patients for iatrogenic opioid withdrawal? Neither do we. Does anybody work in a pediatric ICU? No. Okay, so in Sick Children's Hospital, the largest pediatric hospital in Canada, which is across the street from me, they use this scale regularly. And when a child has received opioids for more than 3 days, they don't stop them abruptly. They taper them very deliberately by not more than 20% daily. They transition from intravenous to enteral opioids, and they will discharge the patient to the ward with this continued taper. Some of the agitation that we see when we abruptly stop benzodiazepines and opiates is probably iatrogenic withdrawal from these drugs. And we haven't paid enough attention to this. There is no validated opioid withdrawal scale for adults in the ICU, but hopefully that will come. It's something for all of you to think about. And if a patient has been receiving either intermittent or continuous opiates for 3 to 5 days, you really should be tapering those opioids, because physiologic dependence is almost universal. So I mentioned some of these non-pharmacologic approaches to keeping our patients more comfortable, talking to them. Many patients will state afterwards that nobody talked to them, nobody told them about their illness, nobody told them about what was coming up and what their prognosis was. And truthfully, we spend a lot more time talking to their families about these things than about them. And as we increasingly keep them awake, we need to involve them in any family discussion. So if a patient is awake, we have our family meetings inside the patient room. So attention to sensory deprivation, glasses, hearing aids, dentures, familiar objects, photos, dealing with thirst and hunger. We keep people unfed for too long, and we stop feeds for very minor reasons. Little things like brushing their teeth. I'm sure I just traveled from Toronto yesterday and I hadn't been able to brush my teeth for 18 hours and I didn't feel human. Little things like this can make people feel very comfortable. Get them out of bed, sleep hygiene, pay attention to noise levels. Most of us don't have ICUs with windows or where we can expose them to fresh air. Lights on during the day, lights off at night. Ask about loneliness, depression, anxiety. Many of these patients are very worried about their family members, what their family members are going through. Avoid restraints. Remove any devices that you can, including bladder catheters, arterial lines, central lines, because they contribute to delirium and agitation and pain. So can we avoid sedation? Not in all patients. There are situations and patients who require deep sedation, and that is patients who are paralyzed. It's very difficult, I find, to maintain lung protective ventilation in an acutely distressed patient with severe pneumonia or ARDS, and often we need to sedate them with opioids and another drug, and often paralyze them, at least in the first phase of their acute illness. status epilepticus, brain injury, and severe shock and severe hypoxemia, and therapeutic hypothermia. So in those situations when sedation is necessary, I generally try to avoid benzodiazepines unless I want some degree of amnesia. And in general, amnesia for the ICU stay is not a desirable outcome. And I showed you one of my slides from my study asking patients if they remembered being admitted to the ICU because we wanted to evaluate ICU amnesia. And we found it wasn't related to the drugs or doses that we were given. So again, it's reflecting an acute brain dysfunction. But amnesia for the ICU stay has been shown to correlate with more symptoms of post-traumatic stress disorder and more delusional memories. And it seems like if patients have this memory gap, they manufacture memories, often incorporating external real stimuli, such as alarms, such as needles, and it's very difficult for them to dismiss those memories as false. So we have to try to avoid that ICU amnesia by minimizing drugs as much as possible, recognizing that drugs may not be the major component of ICU amnesia. There are procedures for which you want patients to have amnesia, such as a chest tube insertion or endotracheal intubation, and in that setting, small doses of benzodiazepines. If patients have been on long-term benzodiazepines, I don't stop them abruptly, I continue them because I don't want them to withdraw. If I know that patients have an anxiety disorder or the families tell me that this patient was very anxious, then I address that with either a very low-dose benzodiazepine or an antipsychotic that has anti-anxiety properties. Use evidence-based strategies, and I'll talk about those, and stop the sedation as quickly as possible. So this is my strategy of multimodal management. I use non-opioid analgesics whenever I can. We don't even have IV acetaminophen. I think it's coming. It would be very useful for us. And then opioids as needed, the lowest dose necessary. I use anxiolytics, I mentioned benzodiazepines, but I also find the atypical antipsychotics are very helpful for anxiety. I use sleep aids, trying to avoid benzodiazepines. And these are the sedatives that are available to all of us. I still feel like our sedative armamentarium is small, and many of the drugs are associated with side effects. And as I said, I use quite a bit of antipsychotics, not for delirium, but for agitation or anxiety. And the reason I say not for delirium, because there is zero evidence that the use of antipsychotics prevents ICU delirium, treats ICU delirium, or improves outcomes related to ICU delirium. So if a patient has a hypoactive delirium, there is no indication to give them antipsychotics, and it can cause adverse effects. My strategy for agitated patients is a sequence of strategies. I start out with sedative infusions, and as I mentioned, physical restraints only if needed for the very agitated patient. And then longer duration, always give analgesics. The antipsychotics I mentioned. I find clonidine can be a very nice approach in hemodynamically stable patients. It is a sedative. It is also a good drug to treat withdrawal syndromes. Propranolol I've used as a very mild sedative in people with anxiety. And then I mentioned sleep aids and benzodiazepines. And I think the secret, this is a nice schematic from a brief review by Jean-Louis Vincent and some colleagues. And I think the secret here is early implementation. From the time the patient is admitted to the ICU, the goal should be comfortable, cooperative, and calm. I mentioned Yahya Shahabi's work. So if you have a patient who's admitted to your ICU, our previous strategy would be deeply sedate them, intubate them, put the lines in, and give them a bit of a rest, and then the next day think about starting to wake them up. But that strategy is associated with worse outcomes. So from the moment they enter your door, the goal should be to keep them awake, comfortable, and cooperative. And with an analgesia first strategy, which is my strategy, sedatives minimized and targeted, and titrated to a specific goal. And then other issues: mobilization, sleep promotion, environmental modulation, family engagement. So how do we achieve our goals? I already mentioned symptom-based management. There's strategy. Thomas Strum's group has looked at complete avoidance of sedation, intermittent rather than continuous sedation, the use of protocols, the use of daily sedation interruption, the combination of those two, and then drugs that don't accumulate, because much of the adverse effects associated with drugs we used to use was associated with prolonged duration of effect. So analgesia without sedation. And this is on the Society of Critical Care Medicine website. There are some slides that you can all download. They're educational, related to the new PADIS guidelines. And this is one of their slides, and I really quite liked it because one must stay on top of patients' pain, because inadequate pain assessment and treatment can lead to agitation, increased sedative use, restraint use, coma, delirium, and impaired rehabilitation and mobilization. So I mentioned Thomas Strum. This was a pilot study published in 2010. This was their single center pilot, and they called it a protocol of no sedation, because the intervention group received morphine intermittently for pain and no sedatives, whereas the control group also got morphine but received propofol and then a midazolam infusion. Both groups had daily sedation interruption, and they were titrated to a Ramsay of 3 to 4. And the results were quite remarkable. The no sedation group in green was extubated sooner, 4.2 days, and spent less time in ICU and was discharged from hospital sooner. More of them had agitated delirium, 20% versus 7%, and therefore got more Haldol. But this was more a reflection that the patients were awake and the delirium was recognized. Interestingly, in the intervention group, only 18% of them ever required a sedative infusion, and that was essentially the ARDS patients, and as I mentioned, to enable lung protective ventilation. So using this strategy of morphine or any analgesic, opioid analgesic, given intermittently, you can avoid sedatives in 82% of patients. So really wonderful strategy. Now, some of you may have been at the ESICM meeting here this past year, and the results of the large multi-center RCT were revealed. It's in press, and I've heard from Thomas Strum it'll be published in the New England Journal of Medicine, coincident with the Society of Critical Care Medicine meeting later this month. It was called the Non-SEDA trial, 8 centers, over 700 patients. The primary outcome was mortality. The study did not show a difference in mortality between these two strategies, but it did show a difference in the incidence of coma, delirium, and reduced venous thromboembolism. So I wouldn't see that as a negative study. I wouldn't see that as, oh, I shouldn't use this intervention strategy. I would interpret it as patients who received morphine only had as good an outcome as patients who got sedatives. There was no advantage to giving sedatives, and then maybe there were some benefits. And I strongly disagree with powering sedation studies to mortality. We will never show a mortality benefit with a single intervention which is relating to sedation. I'll skip that. Now, sedation protocols. This was the first study that evaluated a sedation protocol in an era where patients were kept deeply sedated on infusions of benzodiazepines and opiates. And it was a very simple strategy. It was directed by bedside nurses. They had a protocol whereby they reduced patients' sedatives and opiates. And is pain likely? Yes, so start fentanyl and then transition to an infusion if needed. Is agitation causing problems? Yes, then start benzodiazepines and transition to an infusion if needed. And then they kind of lived down in this area here. Targeted sedation achieved, yes. So if the Ramsay was 3 or 4, there was the constant effort to reduce both the opioid and benzodiazepine exposure and turn them off. And I think that's the part of the protocol that led to improved outcomes in the protocol group. The duration of mechanical ventilation was shortened, the ICU length of stay was shortened with that very simple protocol run by nurses. The nurses didn't have any challenges, and there was no downside. There was no adverse effects related to the protocol. Patients were discharged from the ICU sooner. Half of them had tracheostomies, 13% versus 6%. And the sedative and opioid exposure was reduced. So that was a single center RCT, but subsequently there's been dozens and dozens of quality improvement studies published showing that implementation in your ICU of a scale and a protocol, or a scale alone or a protocol alone, results in reduced ventilator days and ICU length of stay. So there really doesn't seem to be any downside to a sedation protocol. You're probably all using more and more protocols. They have many advantages. And the biggest advantage, of course, is promoting the use of quality of proven strategies, evidence-based care. Now, this was another study which had a very similar design, and it was published 10 years later from Australia. The first study, the Brooks study, was from the US. And patients in a single center were randomized to protocolized sedation or usual care. And in this study, there was no difference in any outcomes at all. And again, there's different ways to interpret this. This doesn't mean that a protocol is not useful. The reason this study was negative was that the usual care had evolved over 10 years. The nurses are advanced practice nurses in Australia. There are no respiratory therapists, so the nurses manage the ventilator as well. So the nurses were more trained to recognize deep sedation and recognize the adverse consequences of deep sedation, in that my patient's not weaning. So it doesn't show that protocols are not helpful, but that a protocol may not be necessary when your usual care is already targeting light sedation. Now, daily sedation interruption. This was a single center study published in 2000. J.P. Kress was a critical care trainee at the time, a fellow, and they randomized their mechanically ventilated patients to usual sedation weaning done on rounds by the physicians, or once a day. The infusions of benzodiazepines and opiates were stopped. The patient was assessed, and the decision was made based on how the patient woke up, whether the infusions would be restarted, and they were restarted at 50% of previous doses, or not restarted, and the patient was managed with intermittent dosing. So it's not in the paper, but J.P. Kress or his research nurse sat by the bedside of every single patient during the interruption, because the nurses in his ICU were too busy to be able to sit there, and the nurses were too worried about the patients getting agitated, having pain, and pulling out their endotracheal tube or other devices. Nevertheless, the duration of mechanical ventilation and ICU length of stay were significantly reduced with this simple strategy. The doses of benzodiazepines were reduced, midazolam dose by 50%, and the patients spend most of their days awake. They had fewer tests to evaluate coma because they had less bioaccumulation of drugs, and there was no increase in adverse events. And in fact, there were other advantages to daily interruption: reduced symptoms of PTSD, reduced complications of critical illness, and there was no increased risk of myocardial ischemia with that strategy. So many, many years ago, we asked the question, if sedation protocols are good and daily interruption is good, then why not use both strategies to further reduce sedative and opioid exposure? And that's what we did. In a multi-center trial in Canada and the US, which included surgical and medical patients, we managed all patients with a nurse-directed sedation protocol, and they were randomized to daily sedation interruption or no daily sedation interruption, with the hypothesis that this group of patients would do better than this group. We didn't find that. The duration of mechanical ventilation was identical in the two groups. However, surprisingly, we found that the group that we thought would receive lower doses of drugs got more doses. So higher doses of midazolam, higher doses of fentanyl. And we think it's because I heard a lot too about how the nurses were very nervous about daily interruption. They didn't like it. I had some nurses that absolutely refused to do it. And they were worried patients would be uncomfortable or that they would leave the room and the patient would self-extubate. So I think what happened is around the time of the interruption, when the infusions were restarted, the nurses gave boluses, multiple bolus doses, and they ramped up the infusions quickly after they were restarted. So time to successful extubation was identical. And what this tells us is that if you use a sedation protocol, which incorporates a scale in your ICU, and you target light sedation, there's no advantage to daily sedation interruption. And I can tell you my nurses were very relieved when we decided we didn't need to use daily sedation interruption anymore. When we asked them the workload associated with the two strategies, with the question, how difficult was the patient's management during your shift? Overall, the workload was scored higher for the daily interruption strategy than the protocolized sedation strategy. And it may not look like a big difference in the VAS score from 1 to 10, but this value was based on over 10,000 data points. Subsequently, there have been multiple systematic reviews, including from Lisa Burry, one of my colleagues, showing that daily sedation interruption is not associated with more rapid removal from mechanical ventilation. There's this one study of patients who came to the ICU after abdominal surgery, whereby immediate cessation of their sedation compared to weaning was associated with a significantly shorter duration of mechanical ventilation. Now, propofol and dexmedetomidine, we call midazolam Versed in Canada. It's the trade name. And this is a slide I found on Twitter where there's a Versed firming serum, overnight facial peel. So I thought that was quite comical. It may be that benzodiazepines are associated with higher mortality than propofol. There's no huge randomized control trial showing this because it would take a very large trial. And Leonardo and colleagues took an approach where they used propensity matching to look at this specific question. And in a very large database, found that 2,200 patients receiving primarily midazolam, when matched for 15 variables to patients primarily receiving propofol, had a significantly higher mortality, 28.8 versus 19.7. Similar for lorazepam, significantly higher ICU mortality compared to propofol. Hospital mortality also higher. Why that is, it's not clear, but overall we need to avoid benzodiazepines, and there's cautions throughout the medical world, including in our older patients. In children, it seems like midazolam is associated with more emergence agitation, which probably is followed by more analgesia or sedation to deal with that, and then cognitive dysfunction in long term. I showed this already. So dexmedetomidine is something, who uses dexmedetomidine here? Okay, yeah. It's an excellent drug. It has multiple desirable clinical effects. You've probably already seen or also seen that it has adverse, mainly cardiovascular effects, bradycardia and hypotension, but most people don't use a bolus anymore, and the infusion is less associated with these adverse effects. So the nice thing about dexmedetomidine, which you all know, is that patients are arousable. They look like they're asleep. You shake them, they wake up, they interact. There's no respiratory depression, and you can extubate them while they're receiving dexmedetomidine. Now, there have been many RCTs evaluating dexmedetomidine because people thought this was going to be the miracle drug and was going to reduce duration of mechanical ventilation and reduce delirium. And I think there is a niche for dexmedetomidine, and I think this study captured this niche. And this is when I use dexmedetomidine because the cost is prohibitive. It still costs 400 times as much as the opioids and other drugs. So we honestly can't afford to use dexmedetomidine in every patient who's mechanically ventilated. So in this study, they enrolled adults who continue to require mechanical ventilation only because their degree of agitation is so severe as to make lessening their sedation and extubation safe. And they had specific criteria for that. And in that population, the duration of mechanical ventilation was shortened. It was a small trial and it was stopped early and there were baseline imbalances, but this is the type of patient population I use it in. In other RCTs that have been powered at mortality, there's clearly no difference in mortality if you manage people with dexmedetomidine versus other drugs. In this study, the only positive outcome was well-controlled sedation. But if you think about the use of dexmedetomidine in all patients who require mechanical ventilation, this too is really unaffordable and not an adequately positive outcome. So Yahya Shahabi's study published last year, New England Journal of Medicine, 4,000 patients, the ANZIX group, and powered at ICU mortality. And there was no difference in mortality, I already mentioned, no difference in any of the secondary outcomes. But the problem with this study is that, I'll skip this. The problem with this study is there was too much overlap. And as you know, dexmedetomidine doesn't, when desired, doesn't give you deep sedation. So the dexmedetomidine group in blue, many of them got other drugs. Sorry, I can't see. So this is dexmedetomidine in blue. So many of them received propofol, many of them received midazolam, and many of them got fentanyl at a similar proportion as the control group. So there was inadequate separation of these two groups to really call this a dexmedetomidine only group. And concerningly, in the dexmedetomidine group, there was a higher incidence of bradycardia, hypotension, and prolonged sinus pause. And 7 of these patients actually required cardiac massage thought to be related to the drug. Now, systematic reviews too and meta-analyses of dexmedetomidine. This one shows a mean difference in the time of extubation of less than half a day, but this meta-analysis included all surgical trials. And as you know, early dexmedetomidine literature is in the cardiovascular surgery population. So in all comers, you can shorten duration of mechanical ventilation by less than half a day. But again, it would mean treating everybody with it. I'm going to skip this. So nighttime administration of drugs is a big issue. And within the sleep study, we found that regardless of what strategy they were randomized to, sedation protocol or sedation protocol plus daily interruption, when we compared the doses received during the day 12 hours versus the night 12 hours, the nighttime doses were significantly higher in all comers. And we're not the only ones that have shown this. Other studies have also shown that nighttime doses go up. Why is that important? It does have consequences because we found that higher nighttime doses were independently associated with failure to pass the spontaneous breathing trial screen the following morning. And when they had an SBT, failure to pass the SBT and failure to be extubated. So again, we know why patients might get more sedation at night because people feel that they need to sleep or rest, but that's not the case. And then briefly, physical restraint. This is an area of interest of mine. I don't need to go into the adverse consequences of physical restraint, both physical and psychological. And physical, there's been cases of psychiatric patients dying while restrained because of asphyxia or the hyperthermia associated with agitation. And within the sleep study, we asked patients about their memories, and we didn't ask specifically about restraints, but patients volunteered these restraint memories that were very disturbing to them. Restraint use varies around the world. Within the sleep study, it was 76% of all patients had restraints at least once during mechanical ventilation. In a large Canadian audit done by my colleague Lisa Burry, 53% of patients, and this was representative of thousands of patients, were restrained at some point. In the Price study, it ranged from 0% in the UK to 100% in Italy. And also there are countries where there are no guidelines or local regulations about restraint application, removal, monitoring, including in Korea and Egypt. And then interestingly in France, In 29% of ICUs, physical restraint was used in more than 50% of wake, calm, and cooperative patients. In our time-dependent multivariate analysis of delirium, we found that restraint use prior to the occurrence of delirium was associated with a hazard ratio of 1.87 of delirium. So putting restraints on increases the risk of patients getting delirious. We also found that restraints were associated with more drug uses, benzodiazepines and opiates. And the feeling that restraints prevent accidental extubation is a false one. In fact, placing people in restraints can increase the risk of accidental removal. And this study showed an odds ratio of 5 times greater if patients were restrained. I don't think I have enough time to get into sleep. Just briefly to say that patients, a notable percentage of patients don't get enough sleep in the ICU, and they cite noise, bright lights, speaking, people entering the room. And when we asked patients about what we could do to help them sleep, closing doors, blinds at nights, reducing interruptions, use of a sleeping aid, lights, visible clock in the room, and removal of alarms overnight. Maybe I'll just stop there and see if there's any questions.
Hello, very nice talk.
Thank you.
What is your experience with melatonin?
Melatonin. Yes, that's a good question. I think I had it there, right? On list of sleep aids, yes. My personal experience is it doesn't work when I fly. but there is some nice literature and increasing literature on the use of melatonin in hospitalized patients. And overall, if you combine critically ill and non-critically ill patients, it seems that melatonin, without really being able to measure sleep in the ICU, because it's very difficult to measure sleep, but it may show a reduction in delirium incidence in hospitalized patients, potentially mediated by sleep. My colleague Lisa Burry is doing a pilot trial of melatonin to prevent delirium in our ICU, just 50 patients looking at feasibility, and she has 3 more patients to recruit, and we'll go from there. But I don't see a downside to using melatonin in the ICU, especially in patients who are using it at home, because it's a very safe drug compared to the other drugs that we can use. And there is a melatonin deficiency in hospitalized patients, partly related to the lack of sleep-wake cycle regulation.
Hello, thank you for your interesting presentation.
Thank you.
My name is Willem Kastilma, I'm from Amsterdam. My background is an ICU nurse, and I was very interesting talk about keeping patients awake and not using physical restraints and having adequate pain treatment. And my experience is that when you do not sedate people in the ICU, it really puts a lot of effort on the nurse to give enough not guidance, but support of the patients. And how do you organize that in Toronto? I'm really curious.
Well, that's what I was going to talk about. But so it's a matter of changing the culture, and you know, culture does not change quickly. Even doing the sleep study, as I said, there was a lot of resistance to using light sedation, and it's all around education. It's around educating about the benefits of benefits of light sedation for the patient and the families. It's also supporting the nurses' fears and anxieties because they're real. And it's about having toolkits for nurses to use when patients are agitated. Because the most fearful thing is that my patient gets agitated, I don't have a sedation order, I don't know what to do, and the patient's going to pull out her tube. So it's support, whatever support is required to change that culture. And I don't know what your nursing ratio is.
Yeah, that's because I come from an ICU where they have a 1 nurse to 2 patients ratio, and I spoke to people in Scandinavia, they have a 1-to-1, and they, well, that of course gives you more time to...
So ours is a 1-to-2 ratio for many patients, and it's still possible. Yeah. One thing I find is if you expose patients to benzodiazepines early and then stop them, they develop this emergence agitation, and it's very difficult to manage them. They get confused. If you don't expose them to sedatives early and aim to keep them awake from the beginning with all of the environmental and family presence that I talked about, it is possible, but it takes a team approach. And this is a nice study about interprofessional team rounds, which includes nurses, pharmacists, social work, physiotherapy. One person cannot do it. You need champions, of course, but you need buy-in from the whole team. And there's no one quick answer to your question. It's starting slow, and it's repeating the same message a million times and getting the families to help you as well.
Thank you.
Hi, Jordan Boker. First of all, thank you for the wonderful presentation. You definitely gave me at least a lot of things to think about.
Good.
I'd like to ask you, do you have any experience with using valproic acid when it comes to avoiding benzodiazepines? Because in the past year or so, some of our colleagues from the Department of Psychiatry actually advised that we might try it.
Oh, I don't actually. So as a mild sedative?
Yeah.
Oh, no, I don't. Yeah, thank you. We're increasingly looking at using ketamine in the ICU because it's a safe drug, not associated with respiratory depression, and it reduces analgesia and the analgesic needs as well. But there's been no trials looking at ketamine for mechanically ventilated patients. Okay, well, thank you for coming. Enjoy the rest of your day.